عليكم جميعا.
عليكم السلام ورحمة الله وبركاته أستاذنا.
طبعا احنا نشكر الدكتور الأشهر كالمعتاد على انا مش عارف هي ما ظهرتش ليه، ثانية واحدة. على المجهود العظيم اللي انا مش عارف الشير سكرين، ثانية واحدة. انا بغلط.
افتح الباور
انا بعمل غلطة، انا مؤاخذة.
تيمور.
انا برجع تاني اي
تمام.
ايوه تمام كده.
يس سير.
طيب يعني نشكر الدكتور الاشهب ونشكر التيم بتاع بنها اللي الحقيقه دايما بيبهرنا بالمجهود العظيم اللي بيعملوه. وان شاء الله we shift to the English language because I understand that we have a great deal of surgeons from abroad. My talk is very concise and simple and might be of interest because of the not common presentation of such a case. I'm talking about marginal ulcer in neuropathic foot affected by leprosy, lepromatous leprosy. It's a case report with some short review which is going to remind us all about this not very common presentation. We have two learning points. The message is simple. The first point is that although not commonly seen, we have always to remember that lepromatous leprosy is one cause of neuropathic foot. It's a cause of neuropathic everything nearly, but it is one cause of neuropathic foot. The second point is that neuropathic foot, when it produces an ulcer due to any pathology, may show malignant transformation over years. This malignant transformation, when it becomes a squamous cell carcinoma, which is the most common, is referred to as Marginal ulcer. Our case is a 62 years old lady, non-leprotic, was not treated in a leprotic colony as the usual in Egypt. She was treated at home. She presented with bilateral foot problems. The right foot had a big ulcer. The left foot had a smaller ulcer in the sole. Both ulcers were in the forefoot. Here we can see the skin with the characteristic papillomacular rash, which is anesthetic. Every patch of these small areas is anesthetic. And we can see the deformed toes in both feet. She had no inguinal lymph nodes, and she had -3 successive smears for the Mycobacterium lymph. This is very important to know if the patient has active disease or not. Patients with -3 successive smears with 1 week interval are negative. They are not infected. This is the appearance of the feet of the patient. As we see on the left side, the sole ulcer is dry, and actually it managed well later on by modified weight bearing and dressing and local treatment. The Cam Walker solved the problem on the right side. The left side was a little bit more problematic. It doesn't look really nice. We notice a big ulcer, but we notice that she still had 5 toes. The patient consented for medical photography. I find it a good chance to remind the audience with the characteristic faces of leprosy, which is usually referred to as leonine facies, and to another sign, which is also characteristic of leprosy, which is the disappearance of the outer half of the eyebrows. This is the first sign that appears in the face. After that, the eyebrow disappears, the hair of the eyebrows disappears totally. This is the X-ray of the patient at the presentation. We could see that the affection by the neuropathy of leprosy is rather distal. It's not in the midfoot. It's not in the tarsometatarsal area. It's more distal. It is characterized by disappearance of bone. It is characterized by thinning of bone with little bone reaction. The conservative treatment on the right side failed, and the patient was advised to come in for surgery. She refused, but she came back again after 5 months with this appearance. Notice that the big toe has gone. She doesn't have a big toe. Now she has 4 toes. And the ulcer has grown in tissue. The tissue is protruding outside of the ulcer. The edge of the ulcer is everted in certain areas. She had become anemic because she has daily bleeding. Still, she had no inguinal lymph node. And we repeated the smears, and she is still not infected. This is the lateral appearance of the foot. This is the X-ray of the foot. As you could see, the left side, the toe, the big toe has disappeared, but she still had other metatarsals. And after 5 months, she doesn't have bone actually for all the metatarsals except a little bit on the 5th metatarsal. Again, this is the comparison between presentation and after 5 months. A biopsy was taken from the patient, and it proved to be a squamous cell carcinoma, a marginal ulcer. She agreed on a sign amputation. This is a diagram for the skin flaps of the sign amputation, which is actually the most important or one of the most important steps in this operation, so that to avoid skin flap necrosis. This is after the closure, and this is after the closure with the X-ray. Sign amputation is a tibio-talar disarticulation associated with excision of the protrusions of the lateral malleoli. It depends on weight bearing on the heel pad, i.e. you must have a good heel with heel pad, and preferably a patient would be of a normal stature. Heavyweight patients and obese patients are actually not very good for this procedure because heel pad atrophy occurs. This is the image of microscopy showing profound infiltration with the moderate anaplastic squamous cells. She is actually a grade 2 squamous cell carcinoma, characteristic by cell nesting, as we could see clearly in this image. This is a microscopic image of the resection margin. This was a sign amputation. the resection margin is far away from the lesion, but it is one of the criteria that you should always take to see your resection margin if you are doing a wide local excision. This is another microscopic picture of the resection margin. Now we are going to go to a quick discussion. This is Jean-Nicolas Marginal, the French surgeon, who described malignant degeneration of the chronic skin lesions in 1828, nearly 100 years ago. Most of them were squamous cell carcinoma. A small percentage, about 5%, were basal cell carcinoma. In recent days, the WHO classification puts the microscopic picture of squamous cell carcinoma at 3 levels. Grade 1 is the well differentiated, grade 2 moderately differentiated, and grade 3 poorly differentiated. It is actually an untreated skin carcinoma will cause death by distant metastasis. It's a slow killer. This appeared earlier in chronic sinuses and in ulcers compared to scars. We know that the neuropathic foot can sometimes present with problematic scars or problematic chronic scars, or by ulcers, or by sinuses. The sinus and the ulcer group shows more of transformation to marginal ulcer as compared to the scar group. Metastatic disease from marginal ulcer of the squamous cell carcinoma type varies in the incidence. It is between 10 and 35%. When we compare that to squamous cell carcinoma arising from naive skin, i.e. previously normal skin without previous chronic ulcers, the incidence is between 1 and 10%. Management of marginal ulcer is straightforward. The best treatment is wide local excision. Remember that in our case, we have a peripheral condition, distal foot, but you can have marginal ulcer in any sinus or any area of the body. So wide local excision with 1 centimeter margin is enough as a standard surgical treatment for marginal ulcer. Amputation is indicated when bones, joints are involved. If you like in our case, the bones and the joints are involved of the forefoot. Or in cases when wide local excision is not possible. The operation is indicated especially when you have ongoing infection, when you have ongoing bleeding, like in our case, because the bleeding will never stop without surgery. It's a parenchymatous bleeding. When you have ischemia, or when you have local lymph nodes appearing. The question of local lymph node dissection and excision is controversial. Some authors would recommend doing this as a must if you have local inguinal lymph nodes to dissect it and remove it, and some authors would say it will not change the outcome. Oncologically, from the oncological point of view, amputation is not better than wide local excision if you have the liberty to do any of the procedures in the same patient. What happens if the patient is not smear negative, as in our case? If in the leprotic cases with positive smear test, and you reach the negative status by 3 successive tests, 1 week between each, not by one test. The antibiotic anti-leprotic treatment here is a triple therapy composed of dapsone, rifampicin, and clofazimine for at least 6 months, together with the surgery, of course. The outcome is not bad and it is not brilliant. 98% of all recurrences were seen within the first 3 years, i.e., it appears early. Incidence of recurrence is about 40%. It is less in young age, it is higher in older age. Most of the recurrence is regional, i.e., the area of the ulcer would re-ulcerate again. But distant metastases in the brain, liver, lung, kidney, and the distant lymph nodes have been reported as well. The long outcome is as follows. 5 years survival rate after wide local excision is 60%. After amputation, it is about 70%. If regional lymph nodes are reported, the 3-year survival rate drops to 35%.
لا لو سعادتك مسجله صوت وصوره خلاص هتتقال وسعادتك قاعد بس.
Whether you do lymph node dissection or not.
طب خلاص يبقى مسجله صوت وصوره سعادتك هتكون موجود بالصوره يا فندم.
What are the lessons learned in this short presentation? Do not hesitate to take biopsy from the chronic lesions mentioned. When you see excessive bleeding, when you see increase in the size or depth, when you see associated painless lymph node enlargement in the groin, and when you see an everted edge. Marginal ulcer is an uncommon killer. And I thank you very much for your attention.
Thank you so much, Professor Taimur Al-Husseini, for this very interesting talk. We are not accustomed to hear Professor Taimur speaking about foot and ankle because he's an eminent star in hip arthroplasty, but it's quite obvious that Professor Taimur can speak fluently in any subspecialty in orthopedics. He's an eminent star in any subspecialty. Thank you so much, sir. Now,
thank you, Dr. Taimur, for this fruitful presentation. I have one question, and one of our audience have another one. My question is, I think the key for management of the leprotic problems is early diagnosis. The problem is most of the patient came very late, as I imagine. Can you agree with me on that?
This is true. This patient have been leprotic for 35 years. She went to the asylum, to the leprosy colony in Khanka near Cairo, and she lived there for 5 years, and she received the treatment. And she was smear negative actually for about 30 years. And then she started to have these ulcers. It is probable that people who are not under treatment will have higher nerve damage. That's to say, people who contract leprosy and then are treated will have a slower nerve damage as compared to other group of leprotic patients who did not have early treatment. Once the nerves are affected, clinically they say those with rolling ulnar nerves and rolling common popliteal nerves, even if they are well treated, will have some problems, not necessarily as a marginal ulcer. Yani having marginal ulcer in a leprotic foot is not a common thing, but it is a reminder to all of us, as I said in the learning points. But the complications of leprosy in the term of auto-amputation and the deformity of the foot and the fingers will happen in this group of patients with affected large nerves, i.e., as I told you, you can identify it clinically by rolling the ulnar nerve and the common peroneal nerve in four limbs. Although they do not need to have treatment with Daxon, and they are smear negative and they are not infective, they will have the neuropathic part of the problem.
Thank you so much, sir. We have to go to the second speaker.
I have a comment, please, for Dr. Taimur. in Mansoura, leprosy managed as a Charcot, or Charcot is named, the first case for Charcot is described in leprosy as a neuropathic foot, and there's a problem that. So for me, I think I treated some
Dr. Hani, Professor Hani?
I didn't treat it on plantar ulcer, but in leprosy, treated with in diabetic foot ulcer clinic in Mansoura as the leprosy. And the patient, as the doctors always follow the patients, and if any problems, they send to our unit in Mansoura, and we can do the operation for them. And the result of leprosy, in generally, better more than the Charcot, diabetic Charcot. Thank you, Dr. Taimur.
Thank you so much, sir.
بس بوجه كده شكرا لحضرتك يا دكتور محمد بيه الاشهب وكل التيم في بنها، وبشكركم على اليوم العلمي الجميل ده جدا، وربنا يخلي حضرتك. وطبعا باكد بس مع الدكتور تيمور بيه على التندون بالانسنج، عشان تندو اكيليس دايما بيحصل اكواينس. انا شفت حضرتك معلم على مكان التندو اكيليس في الانسيجن بتاعك او في السكار، ان احنا بنعمل زي بالانسنج. مش كده يعني حضرتك ما قلتش عليه، بس انا حبيت اقول للزملاء ان كتير قوي بيحصل اكواينس التندو اكيليس بيشد الستامب، فدي تكنيكالي مهمه جدا.
دي ديتيلز في السايم ابلكيشن. السايم ابلكيشن يتعمل ازاي ومزايا ايه وعيوبه ايه. هو اي عمليه ما هياش زي ما انت عارف ما بتتعملش كتير يعني، انما السلكتد بيشنتس
هي المشكله ان ساعات بيجي لي بيشنتس عاملين الحاجات الساينز من غير ما يعملوا التندون بالانس، وبيحصل لهم اكواينس، وبتبقى الحته الستامب بتاعت الكيكه بتبقى باصه لتحت. فطبعا فدي يعني فرصه ان انا حضرتك
بالظبط هيحصل مشكله في السكار، هيحصل مشكله في السكار، وفايده السايم ابلكيشن بقى هتختفي.
بالظبط كده،
ما عدتش بتمشي على الهيل باد.
على الهيل باد بالظبط
ما تمشيش على الهيل باد زي ما هو كان في دماغه يعني.
بالظبط كده. متشكر جدا لحضرتك. طيب.
Thank you, Professor Ahmed Philippe. Thank you so much, sir. Now we will move to the second speaker, Professor Hani Mwafi, Mansoura University, and the eminent shining star in the sky of foot and ankle surgery. Professor Hani, you are very welcome.
Okay, thank you, Professor Ashab. Thank you for your effort, and I'm already recorded by my
Khaled.
Yes, Khaled. خالد
حالا احنا شايفين السكرين يا دكتور هاني.
Egyptian Orthopedic Association for the monthly clinical meeting, but indeed I would like to the man behind this meeting, which Professor Al-Ashhab is the head of the orthopedic department of Benha University. Actually he did a good job for I think since 1 year for virtual or for many courses he did for his department, but not only for his department, but also I think for Egypt. Also, I would like to say not only Egypt, but also all over the world. So thank you, Professor Asha. Today I'm speaking about, my case presentation about how to manage plantar of Charcot foot ulcer. But before to present my case, actually I'd like to say, is Charcot arthropathy in ulcer is vascular or mechanical? Actually, many researchers said that the common mechanism of ulcer in Charcot foot is foot deformity and neuropathy. So this is bring about skin breakdown in person with diabetes, as due to mechanical failure of the underlying insensitive neuropathic joint, leading to progressive pressure, necrosis, and also eventually ulceration. So By analysis, this works if there is disturbance mechanics. It means leading to deformity. And this deformity, the affection of this deformity is pressure necrosis and, of course, pressure ulcer. But maybe leading to osteomyelitis or without osteomyelitis. But the ulcer, it is a pressure ulcer in foot. In our department and also in our unit, we make many research about the management of diabetic ulcers or Charcot ulcer from orthopedic point of view. And also, we said that the mechanical correction of the foot and ankle is important for healing of the Charcot or diabetic foot ulcer or not. So I will present two cases. The first one is the forefoot ulcer, and the second is midfoot and maybe extend to the hindfoot. But before we were speaking about this ulcer, actually in our foot and ankle unit, we have an own classification, which this classification, it will be published in International Orthopedic Journal, and it will be available online in the next week. And this is in Charcot arthropathy of the foot and ankle, radiographic and clinical pattern with related outcomes. The classification depends on, it is an easy classification. It is two types. This is the first type in any one region affection only, and the second type is that more one region affected. And each type are divided into 4 cases. It depends on the first is stable or unstable, with deformity or without deformity. And the final one is the end is the D, which is the deformity with or without ulcer, mechanical ulcer. So an example for this cases, this is a lady about 57 years old, has diabetes, and also she underwent amputation of the big toe and a little bit from medial ray, and she came presented by this and also the X-ray. If actually we analyze the X-ray and also the patients, we found that there is a little bit second tooth is dislocated, and also the first metatarsal angle, it is little bit increasing, and the line of the joint between mid cuneiform with the first metatarsal, it is little bit is oblique line. So what we did just an excisional arthroplasty for the second toe, and also we did what's called an Lapitus operation here with just one screw. And the presentation is the first. This is before operation, and after 24 days, the ulcer is completely healed. We didn't use any curette or anything in this ulcer. Just we do an betadine, and just that only affected betadine only, and we covered with those, and that's it. And the patient after 24 days, and after 3 months, 6 months, patient is, I think it is completely closed. And if we see the skin, looks like a normal skin, which it is a benefit for the patient and also a benefit for the surgeon. And this patient, the same patient, after 5 years, she was happy about this results, and she was walk without any deformities, any problems for her. And so we consider this is a type 1 but type 1D from Mansoura classification, which is type 1 for our results, which always get a good results. The second case is in midfoot, there is problems and there are many regions affected. So we said that this is a prenavicular affection. The prenavicular affection here, but if it's stable or not, we have to do an X-ray, a standing X-ray, and we show that there is the pressure here. This is the ulcer, and this is pressure in this. So it is unstable. So it is type 2. Actually, it is unstable, and also it is with ulcer. So we need to correct the mechanics of the foot, and we do an arthrodesis to the middle ray and arthrodesis to the lateral ray. And this is a patient after 4 days from the operation. It is little bit is gradually increasing, and the colloid or everything is begin improve. And the patient after 10 days and 20 days here, the ulcer become little bit decreased in size. And after 28 days and 34 days. And the patient after 2 months here, and the ulcers completely disappear, and a little bit is good. And this is an X-ray after 1 year, and this story after 6 months. And after 2 years, we found that the patient here, it looks good, but the X-ray is a little bit, there is a plantar flexion of the ankle joint, and a little bit, I think there is a tightness of the Achilles tendon, and mechanically it is unstable. So after 2 years also, the patient came to us by ulcer here, as you see, and there is a union in many cases, but the patient has an ulcer. And we did revision by placing screws, and we do an subtalar and also subtalar arthrodesis, middle ray arthrodesis, and lateral ray arthrodesis. And this is a patient after 18 months. I think it is going a little bit well, but actually in type 2D in Mansoura classification, we always, you couldn't say that, okay, this is a good solution or good results, but it is little bit in the results is less than the results or not good like type 1. So we can conclude that analysis of foot deformity biomechanically and correcting or improve the foot mechanics is a cornerstone in treatment of diabetic foot ulcer in charcoal, associated with bony deformity, and always it is usually decrease the recurrence rate. If we know that the recurrence rate in normally is usually in about 25% in cases in type in charcoal foot ulcer in 1 year, and about 100% in after four years. Actually, here the patient is return the ulcer. The type 2D is return ulcer or recurrence the ulcer after 4 years, but in type 1D and in type 1D in case of the first cases, I think there is a follow-up for 5 years, and the patient is walking normal, and also she become happy with his lifestyle by this way. And finally, I'd like to thank Professor Ashab and also the Egyptian Orthopedic Association.
Thank you so much, Professor Hani Mwafi. Thank you so much, our beloved professor, for this very interesting talk. If we have any questions to Professor Hani before we proceed to the third speaker. Okay, now we will move to the third speaker, which is a very eminent foot and ankle professor and surgeon, Professor Osama Shazli, Ain Shams University. Professor Osama, you are very welcome, and congratulations for the very interesting new book, أوراق شمعون المصري. It's very interesting book, sir.
Thank you very much, Dr. Ashhab. Thanks a lot. I'm really happy to be with the Egyptian Orthopedic Association as well with the Orthopedic Department of Benha University. It's always my pleasure. Also, I'm so happy to be with my professors in Foot and Ankle Society, Dr. Hani Mwafi, Professor Atif Al-Beltagi, and Professor Ahmed Khulif, and my colleague Ahmed Rami. I will share right now my screen. I'm happy that Dr. Taimur Husseini, my dear professor, also had presented a case of neuropathic foot, and Dr. Hani had presented a case of diabetic neuropathic foot. I will show a case earlier before having neuropathic ulcers, which is a mid-foot charcot case. I hope you will like it. Well, I will just present this case quickly. We have here a case of a 63-year-old male. He is active businessman. He has many factories, and he goes for watching and observing his job and work. He's diabetic for 22 years, and he has insensible foot. And he was complaining of recurrent painless swelling and edema over the 2 weeks before he started to seek medical advice. I want here to say, as a classic scenario, which we always see in our orthopedic foot and ankle clinics, and I think this scenario is repeated also in different regions in the world, that the patient, diabetic patient with a swollen foot, first he consults the physician, internal medicine physician, and he goes to a diabetologist to consult him about his swelling. The first and initial diagnosis made by diabetologists in most of cases is a diagnosis of cellulitis. And they start to refer him into a general surgeon or to a vascular surgeon. And the vascular surgeon usually makes Dopplex to check and to rule out presence of any vascular ischemia or problems. Then he starts to treatment by antibiotics and anti-edema. And after they fail for a long time, they start to consult orthopedic surgeon. And I think this is repeated in our clinics and also in many other regions. This was the first X-ray made by the patient after 1 month of seeking medical advice. As we see here, it's a case which may be similar to that shown by Dr. Hani Mwafi, but it's different as we see here total dislocation present in the two-part joint, talonavicular joint and calcaneocripoid joint without fractures. We cannot see here fracture in the naviculars, fractures in the cripoid, or even in the CT and MRI made by the patients. There were no fractures in this patient. So now, what's the diagnosis of such case? Of course, the diagnosis of such case is a Charcot case, early case of Charcot arthropathy and midfoot Charcot arthropathy. And this is a message for general practitioners and for internal medicine physicians and diabetologists. When they have a patient diabetic with foot swelling and edema, he must to do X-ray to rule out presence of early Charcot like this case. I here just mention, just as a reminder, how to differentiate between infections or cellulitis and early Charcot case. And you can find this in different journals, but the most important is the clinical and the swollen erythematous digits present in infections like a sausage toe will not disappear when we elevate the foot of the patient. And this is a cardinal sign of differentiation between Charcot and infection is disappearance of erythema when you elevate the foot. Besides, the laboratory investigations, of course, in case of infection is much higher Specifically, the total leukocytic count is much higher than in case of Charcot, and also the radiological findings which differentiate both of them. This is the assessment of our patient. This is the elevation test we made. The foot, when it is hanging, it's swollen in the erythematous. When it's elevated, the eczema disappears and it's much better. The patient has loss of proprioception as part of the problem, loss of touch and pain. And these are the laboratory investigations of the patient. CPC of the patient total leukocytic count is normal. Acute phase reactants are slightly elevated. Blood sugar is uncontrolled with hemoglobin A1C 9.3 and renal function is 1.4. Okay. And I think Dr. Hani with us has shown the some of the classifications of diabetic ulcers made by Mansoura, and I congratulate him for this nice new classification which we needed. But we have classifications for Charcot, not for ulcers, like Eichen holes, like different classifications. But in cases of such type of injuries, I think it's not present in classification. If you are going to classify it with Sanders fracture, it's super joint, but usually in super joint affection or Sanders type 3, there is fragmentation and broken navicular and cuboid. Isolated dislocation is really unclassified, and we don't have a classification for isolated dislocation in Charcot case without fracture. This is why I show this case. Also, we have, if we want to classify according to Eichen holes, stage 1, because it's acute stage, but also it's stage 1 with dislocation, not fragmentation or fracture in the bones. When I revised the literature, I found very scanty cases of midfoot Charcot dislocation without damage of the bone and navicular. And in literature, there is one of these papers mentions that in literature, only 15 cases, and this may be the 16th case of isolated dislocation. The timing of surgery here, of course, you know from our practice and from previous webinars that in Charcot, we do in acute stage nothing, just conservative treatment. I have to wait for 3 months until the acute stage pass, and then we can manage in the subacute stage. Now this patient is 1 month after presentation. I think it's different here. We may have some debate about the timing of surgery, when to do it. Should I do it after improvement immediately of condition, after control of hemoglobin A1C, after return of the inflammatory markers? And each decision if to do or not to do may have some pros and cons. For me, if you don't do such case and treat it, although it is in acute stage, I may see this case end in a similar case like Dr. Hani's case, with ulcer in the plantar aspect due to the pressure of the head of the talus. So I went to the decision of early fixation and fusion rather than waiting to bypass the acute stage. And I treated it because treatment in this stage may be easier to reduce the talar navicular joint. It will not be difficult for you. Also, it will avoid impending ulcers and wound problems. And in the cases shown in literature, I found that these cases, when some of them, some papers about acute dislocation in diabetic patients, they prefer to do fixation rather than to do waiting and conservative treatment. Here also, we may have some discussions about the approach. Should we use single approach, midline, or double approach? I prefer also in this case to do double approach, one for the talonavicular joint. And look here at this approach where we can see this is the talar body, it's not the talar head, this is the navicular, and the talar head is in the plantar aspect down. Here is the calcaneocupoid side, the lateral approach for subtalar and calcaneocupoid. I like to use this instrument, which is Hintermann distractor, in order to help me in visualization and preparation of the talonavicular joint. I put it and I separate with it, and I can easily see the joint, and I can remove the talar head articular surface and as well as navicular part. And in the subtalar region also, I use it when it is difficult to open, to see the posterior aspect. This minimizes the problem of traction and wound problems markedly. Then we have to reduce, I have to make the talonavicular angle to normal, back to normal, also the calcaneocupoid, and I make fixation preliminary with K-wires, and then I make definitive fixation using plates and screws, and I put bone grafting for enhancing healing. Post-operatively, these patients, we put them in bulky dressing and backslap, and we remove stitches at 2 weeks. Then we put a cast for the patient. The most important, the patient should be non-wet pairing for this side for at least 3 months. And after that, we can start. This is the follow-up X-ray of the patient, as you see, with good healing in the subtalar joint as well as talonavicular, and there is very good restoration of the talonavicular angle and calcanea pitch angle, which may be difficult if you try to treat this patient after 3 or 4 months. And here is also the AP view and oblique, good healing. Also, the patient was so happy walking simply like that. Yes. And here is also the clinical X-ray. The take-home message here, remember that tuber joint affection maybe represents rare cases. It's 10% of all types of Charcot, but if you have isolated dislocation without fracture, it's very rare. We have some case reports. Isolated dislocation may be treated differently from classic Charcot. We don't need here to wait until the acute phase bypass, but you can reduce it quickly and fix it with proper immobilization and also postponing wet pairing for a longer time. And this may avoid having problems of diabetic ulcers, as we see in the previous lectures. Thank you very much, Dr. Mohammed Al-Ashhab and Benha University and Egyptian Orthopedic Association. I'm so happy being with you. Thanks.
Thank you so much, Professor Osama Shazli, for this very interesting talk. This is as usual from you, sir. Thank you so much, sir. Before we move to the last speaker, any questions to Professor Osama?
Yes, please.
Osama. Good evening, Osama. As usual, very nice, fruitful discussion. I ask you, do you usually use a bone graft in cases of Charcot management? And you recommend that?
Yeah. I always use bone graft in fusion, and especially in diabetic patients, because healing issues usually is delayed and we may have problems with healing. So I usually use bone grafts, especially with such extensive dislocation. You will need to put and support with bone graft with fixation.
Autogenous iliac bone graft?
Yes, autogenous iliac bone graft, yes.
Okay. I have a comment, please, Osama.
طبعا ربنا يخليك.
انت وحشني قوي. انا ما عرفتش اجي لك والله، بس انا فعلا
خلينا بالعربي عشان الخواجات.
ماشي اوكي، بس مش مشكله، بس انت وحشني قوي
اكتر والله.
اي حاجه ثانيه. المهم اوكي. Thank you for your presentation. Thank you for your cases. I will send to you my classification about Charcot. Also, this include this is one region, and I think the first step of acute Charcot is dislocation, which is okay, like less frank dislocation. I think you see that, but if there is displacement, not like your cases in less frank, sometimes you find that it may be stable. If it is stable, I leave it, and for one joint, that's okay. I have wait until the acute stage is completely resolved. Actually, rapid reduction of acute case, yes. I think I'm doubt about that. I'm sorry about it's. Actually, I was scared to interfere in this stage because the results it's not good. Also,
of course, as I said, pros and the cons. You have things to do it early, and you have against, of course, if you do it early. But I prefer in such cases with locations that to do it early, because if I wait, it will be impossible to reduce. If you want to reduce, you have to cut the head of the thallus and put big bone graft and to make realignment again. It would be very difficult, incomplete. I have, by the way, another case which was treated conservatively, and I needed to do it, but because of time, I didn't show it. I could never achieve such nice reduction as seen in early intervention. The only issue is the soft tissue condition. If it is permits to open, you can do it.
Okay, but as for my opinion about firstly, interfere in the acute stage, I'm a little bit scared from this. And also, if you wait, what is your aim from treatment of the Charcot foot? You need a stable foot. If the first time to the patients, I think it is usually, as you know, it is usually will be repeated on another acute stage. So it is better to be calm until everything is okay, and then you can do graft. And also, I have a mini case, and I think you know that without graft, I didn't use graft at all for Charcot, whatever ankle, whatever midfoot, whatever everything, because I'm little bit also scared from infection for the graft, because okay, I know that there is a good blood flow in this area, but actually I didn't use graft. I didn't use even if there is shortening, I'm agree about that. And also I spoke with the patients about there is an shortening in your limb and you can move. Actually, I will send you my papers. Today, I will.
Thank you so much, Professor Hani. We are out of time, sir. So we have to move to the last speaker because we are out of the schedule. The last speaker will be Dr. Ahmed Rami from Helwan University. Dr. Ahmed, would you please start?
Assalamu alaikum. This is Ahmed Rami, lecturer of orthopedic surgery, Helwan University. First of all, I would like to thank Professor Dr. Mimad Hosni, the president of the Egyptian Orthopedic Association, Professor Dr. Abdussalam Eid, the general secretary of the Egyptian Orthopedic Association, and Professor Hani Mwafi, the treasurer of the Egyptian Orthopedic Association. And I would like to express my great appreciation for Dr. Muhammad Gamal Al-Ashab, the head of Benha Orthopedic Department, for his kind invitation. I will start now sharing my screen for our today's case. It's a case of a typical talar body fracture. Here we can see the plain X-ray for a male patient, 43 years old. He's a manual worker and he has a history of fall from height with a closed injury. And as we all see now, there is an intra-articular fracture of the talar body. There is a fracture in the coronal plane, and this is another fracture in the transverse plane. And I think here we can see a shadow of a fragment planted in the body of the talus, and we can see here a loss of the distal end of the fibula. And as we know, in any articular fracture, we have to proceed with the CT. And this is the CT of the case with the coronal cuts. We can see here there's a significant displacement of this fracture line. And this is the planted part of the distal tibia, of the distal fibula in the talar body. And I think it is the cause of this fracture line and this significant displacement. These are the other cuts of the talar body in the coronal plan, and it is complete articular one. And these are the sagittal cuts, as we can see. There is also complete articular fracture with significant displacement, and this is also the planted fragment from the distal fibular fracture. When we revise the classification of the talar body fractures, as it's mentioned in Collins, it's divided into three main groups. Share one group, where we can see a fracture, a vertical one, either in the coronal or the sagittal plane, and share two, where is also a linear fracture but in the transverse plane, and the third type, which is crush fractures. The share one type of fractures is subdivided into four types. Type 1 non-displaced, type 1E is non-displaced, type 1B it is minimally displaced, type 1C it is more displacement with extension into the tibio-talar and the talar-cancalian joints. Type 1D, there is dislocation of the fracture part from the tibio-talar and the talar-calcaneal joints. When we go for the AO classifications, this is the complete articular fracture, and it is also subdivided into two types. The simple one was mild or no displacement, and this is the multi-fragmentary fracture. When we revise the treatment algorithm in Collins, we can see here that type 1A and type 1B are treated conservatively with the low knee cast immobilization for 6 or 8 weeks, while type 1C and type 1D are treated with omnireduction internal fixation. Type 2, where the fracture line is transverse, it's treated conservatively, while the crush type is treated with omnireduction internal fixation. What about the recommendations of AO Foundation? When we talk about the body fracture, the talar body fracture, the articular one, the recommendation is treatment with omnireduction internal fixation, either with screws or screw and blade fixation. So our decision making here for this case, as we can see, it is a talar body fracture, multi-fragmentary. There's a transverse fracture, and this is another vertical fracture with planted fragment from the distal fibula into the body. With the fracture line is completely articular in all plans. So the decision was to proceed for open reduction internal fixation in this atypical case, and we can say that it's atypical because this planted fragment of the distal fibula into the body, and because the formal crush injuries are usually associated with other talar fractures, especially the talar neck, but we cannot see here the talar neck fracture, so we can consider it a typical form of the talar body fracture. We have chosen the anterolateral approach of the talus with lateral malleolar osteotomy because the main fragment of the fracture was lateral, and also the planted fragment of the distal fibula is located also lateral. This is an intraoperative picture. As we can see here, this is the lateral malleolar osteotomy. This is the planted fragment of the lateral malleolus, and this is the talar body of the fracture, and this is the upper surface of the talar body. This is the transverse fracture of the talar body. And this was the post-operative X-ray with fixation of all fragments of the talar body and fixation of the distal fibular fractures with headless mini-fragment screws. And this is a fixation of the lateral malleolar osteotomy and the syndesmotic fixation. When we revise the literature for the talar body fracture, we have found this interesting paper. It was published in 2018, and it's a level of evidence 4. And they have studied 1,527 patients. The open adduction internal fixation for the cases was done in the period from 2007 till 2011, and the complications were recorded for these cases for 4 years. And they have found that the arthrodesis rate at 4 years was 29 cases. It was about 1.9%, and the vascular necrosis was 0%. This was in 4 years follow-up. Our home message is the displaced intra-articular cable body fractures requires anatomical reduction and rigid fixation, and the short-term follow-up of the surgical treatment seems to be promising. I hope that you would like our case, and thank you very much for your attention. Thank you.
Dr. Ahmed Rami for this very interesting talk. Finally, at the end of this session, I would like to thank all our eminent